count the number of QRS complexes in a 6-second portion, multiply by 10, and then you have your beats per minute. This is the 300, 150, 100. So you're counting between your R's how many dark pink boxes you have. And then, I don't know, do you ever even teach anybody this method anymore? No. No, okay. And the recalculators, we're not doing that. No. So if you're looking at the steps to reading an EKG, what's the first thing that you're going to look at?
Counting QRS complex.
Rates. Or counting your QRS complexes, which gives you your rate. What's the next thing that you're going to look at?
P waves.
P waves, or more broadly.
Okay.
Do they have one? Do they not have one?
Do they have one? Do they not have one? Right? Rhythm.
Is it not enough QRS?
So after you can say bradycardic, normal rate, tachycardic, then you're going to look at the rhythm, and you're going to be like, is it regular or irregular? Lead 2, like we said before, is commonly used to determine if your rhythm is regular. No one knows why they chose that one, but they just chose that one. I don't know. And you're going to ask yourself if there's a P wave. So is the electrical conduction coming from the SA node, or is it not coming from the SA node? And then your RR interval is really what tells you if it's regular or not. Presence of a P wave tells me that this is not AFib, but it could still be irregular, if that makes sense. So RR interval assesses your ventricular regularity. And if you have the equidistance between all of your RRs, then you know that you have regular rhythm. We were saying before, you were asking, can you use the 300, 150, 100 if you have something like AFib? Because the R's are not going to be equidistant from each other. They're not going to be at equal intervals. You can use the 300, 150, 100 method. However, it'll be more like an average of all of those than it will be like you just need to look at one interval to tell me what the rate is.
Yeah, it's probably more accurate to do the 6-second strip and count the R waves for that.
Don't mind me.
So we have two. Here's the evaluation.
To determine if you have RR intervals that are equidistant from each other, you can use calipers if you want to be fancy, or you could do what the majority of you are going to do, is fold your paper and then draw lines on the white side of the paper and see if you have equidistance between all of your little blocks. Does that make sense?
Yes.
So if I have,
Sometimes you do need to print it out. A lot of it you can tell by looking at the screen, but sometimes you have to print it out and do the paper trick.
so sometimes I'll take my piece of paper. In the ER, it's usually like somebody's nursing home records or something. And I'll be like, okay, I have a QRS there and a QRS there. So is that the same as that one? And yes, it is. So that means I have regular rhythm. If you want to use calipers and be fancy, all the more.
It's a weapon, I wouldn't.
Honestly, it is a
Point.
freaking weapon. You could stab somebody's eye out with that.
If the rhythm is irregular, then you want to kind of further categorize it. Is it patterned but irregular? Is it completely irregular? And here are some of the words that you can use to describe such irregularity. If you're looking at the P waves and you notice their morphology and their distance from your QRS complex or your PR interval, as you were pointing out before, if that's longer than 0.2 seconds, then you have some kind of block there. These are some different looking P waves based on all of the things that we talked about before. Leads could not be in the right place. You could have hair or sweat or whatever kind of creating artifact. And then we have atrial P waves with a dysrhythmia that can include like P waves in a PAC or P waves that are blocked by something else. P waves with like atrial tachycardia. Those are all like irregular looking P waves. So here we have conducted P waves or P waves that are getting picked up. So my lead is picking up that atrial depolarization, Something is canceling out that depolarization, some aberrant current or something. So now I have blocked P waves or buried P waves or depolarizations that are getting picked up along with something else. More often than not, like the repolarization of a ventricle. This is a wandering atrial pacemaker. So you have P waves, right? Because a pacemaker is supposed to simulate the SA node. So you have P wave, weirdly didn't get picked up for some reason, P wave that's kind of buried in your QRS, P wave that's now inverted, P wave again that's inverted. And this is not uncommon for pacemakers. It just means that the impulse from the pacemaker is either getting shadowed by something else in the current, or it's not strong enough, or maybe it indicates a malfunction of the pacemaker. There's a lot of different things that can change that appearance. So it doesn't always look like this, but it can, the P waves can just look funky. For QRS complex, you're gonna say, is it narrow, is it wide, right? We had that interval of like 0.12 seconds for our QRS. So if it's narrow, it's very small. If it's wide, it's gonna be longer than that.
And we're measuring that at the baseline.
At the baseline.
Yes, at the isoelectric line.
Mm-hmm. PR interval we talked about already. Sinus node, we said, is our pacemaker of the heart, intrinsic rate 60 to 100, so that sets the original heart rate. And these are different rhythms that originate from the SA node. So this is our normal sinus rhythm. Aside from it looking normal, right, we can say with more certainty why it's normal. So I have, can I do this here? So 300, 150, 100, or what is it, 300, 150, 100, and then some, so it's between 60 and 75 beats per minute. You know that you have a P before every QRS, a QRS after every P. So I know that it's a regular rhythm. I look at the PR interval, and it looks normal to me. Does anyone remember how many of that like dark pink box a PR should be? And if you know that a dark pink box is how many seconds?
The dark is 2.
The dark is
3 to
0.2.
4. No, 3 to 5.
The dark pink box is 0.2 seconds, so your PR interval should be less than one dark pink box.
Yeah, because the little pink boxes are 0.04. Right. And there's 5 of the little boxes in the heavy, between the heavy pink lines.
Mm-hmm. This is sinus Brady, right? Because we have, this R lines up pretty perfectly with a dark pink line. So 300, 150, 100, 75, 60, and then some. So that's under 60 beats per minute. We have regular rhythm, right? Even though the P waves are small in amplitude, they're there. PR interval is less than one dark pink box. This is actually a great one to look at. That PR is less than one dark pink box. Does that make sense? Sinus tach. So heart rate's over 100. If you look here, you have like basically two dark pink boxes between each R. So we're looking more at like 140, 150 rate. And then here we have a sinus arrhythmia. What makes it sinus and what makes it an arrhythmia? Yeah, sinus means we have P's. So P before every QRS, QRS after every P. Arrhythmia means we don't have equal RR, right? We're actually getting faster as we go along in P.
Does anybody know what can cause this?
Like,
Breathing. Literally. A lot of young people have a sinus arrhythmia, and it's just breathing.
when you inhale and your diaphragm depresses and your lungs fill up with air, it can almost for a second like cut off the blood moving throughout the heart. So it looks like you're like taking a longer beat or longer between each beat, but it's really just because you are moving air.
No question. Can that also be like heredity? Because I know people who have a family member that born with arrhythmia. That is naturally always like that.
Yeah, not every arrhythmia is dangerous, if that makes sense. Sinus arrest, arrest meaning stop. So we have a period of time, quite a few dark pink boxes where we aren't producing a beat. And then we talked a little bit about a few of these atrial dysrhythmias. We'll talk more about them with the pictures. This was our wandering pacemaker. Our premature atrial contraction. Basically, the electrical impulse in the atria occurs before the regular rate of the rest of the contraction. So it just means that we had an early beat at some point, which like reset the clock. Not inherently dangerous.
And so when are you getting to the point of PACs that you're looking at it being a problem?
So in this strip, I have like one PAC. I'm not worried about that. If I have a PAC every other beat or PACs in a row that are now messing with the normal rate of that heart, that's when I'm a little bit more concerned. But people have PACs all the time and it's not dangerous. So it's really more how often are they happening? Is the patient having symptoms when they happen? If they have a run of PACs, are they having symptoms? Atrial tachycardia. So depolarization is overriding that intrinsic rate of the SA node, and you have a heart rate that's super high, concerningly high. Your P waves can have different morphologies here. Some of them can be inverted, and you have P waves that can also be buried within your QRS complexes because they're so narrow, right? If you have beats happening so frequently, then you don't really have the time to go through the whole process of seeing deflections.
How fast is that strip? About 150. Right?
Multifocal atrial tachycardia. Basically, P waves are changing morphology because you have multiple foci from where that electrical impulse is originating. And then you have supraventricular tachycardia. So supraventricular meaning higher than the ventricles, tachycardia meaning fast. So you have P waves that are usually not discernible, and your PR is so short that it's non-existent, and your QRS is pretty narrow.
So when we get to the ventricular dysrhythmias, the way you're gonna tell the difference between an SVT and a VTAC is how narrow or wide your QRS is. Okay, so this is, how fast is this one? Pretty fast, right?
Like, two.
Maybe 250, right? So, does your heart have time to refill with blood if it's beating this fast? No. So your patient's gonna be symptomatic, okay? You're gonna have to intervene in either with medication or with electricity. Most likely electricity this fast, okay? If it's a VTAC, you're gonna see it's gonna be wide and going fast.
AFib, so AFib can be either rapid or not rapid, right? Depending on its rate, but the characteristic part of the atrial fibrillation is what? No heat waves. Because you have pacemaker cells within the atria that are fibrillating or randomly sending out electrical impulses. Therefore, there's not one organized impulse coming from the SA node. And that's why you end up not getting a P wave. It's irregular because as these atrial pacemaker cells are fibrillating or randomly sending out impulses, they're doing it at different rates, which is why you have a random one, a random one, random one, random one, and then it changes your rate. So this is when if you're using your 300, 150, right? 300, 150, 100, 75, 60. Okay, so this rate is 60, but then this rate is 300, 150, 100. So you are more likely to use the let's count our QRS complexes with that one, or look at the top of the paper and see what it said. So your the 300, 150, 100 method just doesn't work as well there. Atrial flutter is this sawtooth appearance between your QRS complexes. You have in the atria fluttering impulses, which are causing what look like P waves. The atria is trying really hard to depolarize, but it takes so many tries to depolarize for it to actually make its way to the ventricles, for the impulse to make its way to the ventricles, causing ventricular depolarization and contraction. Junctional dysrhythmias, you can have junctional tachycardia, premature junctional complexes. These are beats that occur early in a cycle. There's no compensatory pause. So before, when we saw the premature atrial complex, there was a compensatory pause as like a reset, and then it went back to its normal beat. This one doesn't really have a compensatory pause between the junctional contraction and the next beat. But sometimes it's hard to know if you're looking at a junctional complex versus a PAC. The junctional complex usually won't have a P wave. A junctional rhythm, P waves are usually either absent or buried within or after the QRS. So you really are focusing at the AV node being the pacemaker of the heart, because the SA node isn't able to catch up. If that makes sense. So your heart rate is usually going to be slower. You can have an accelerated junctional rhythm. Your P wave, again, is going to be either inverted or absent. This happens less so than a slow junctional rhythm. Junctional tachycardia, heart rate is going to be between 120 and 220. Your normal QRS duration, unless you have aberrant conduction, unless you have you also have a QT problem, like your patient was taking Zofran on top of this or something like that.
Okay, stop there. We're not gonna do ventricular.
We're not doing ventricular. Okay.
So, couple of things. notice on all these slides, there are these on the bottom, right? They're there for a reason. You have to approach reading EKGs with a system, okay? Because if you don't, you're gonna miss it. You're gonna miss stuff, okay? The other thing that you have to know is what the rules are for the distances and what is normal, okay? So that's gonna involve some memorization, all right? So you have to know that the normal PR interval, for instance, is 3 to 5 small boxes, okay? And if it's longer than that, it's a first degree block, right? There's no way around this. You have to know those things, right?
Unicorn.
Atrial flutter, okay, it's super fast, right? But is it? What's happening here?
That's squiggles.
Lots of them. So your heart rate, you have your atria going at a different rate than your ventricle, right? So when you're looking at heart rate, you say, wow, there's not that many of those QRS complexes. So your ventricular rate is different than your atrial rate. You think that can screw somebody up? Yeah, right? So the rhythm is irregular if you look at it, right? So you can see that the R to Rs are not the same distance apart from each other, right? So you looked at the rate, you're looking at all the parts. Are there P waves there? There's something, but they're not P waves, right? There's QRSs, and they're narrow, so they're within the 0.04 to 0.12, so they're normal. Do you have T waves? There's something's there, right?
And then who the F knows where their T waves are?
Okay. So you know your rate. You know that it's irregular. You know that there's something between the R to Rs, but it's got, what does that look like to you? It kind of looks like a sawtooth, right? This can be hard to pick up when there's not that many sawtooths, but this one, there's like 3 of those, so that's like a 3-to-1 conduction. So you get 3 atrial beats for 1 ventricular beat, okay? So for each one, you're going to look at are there the rhythm, are there P waves, what's the PR interval, what's the QRS, and that will help you, and knowing the rules will help you figure out what kind of rhythm it is, right? A lot of the rhythms that we see are what they're normally in, and is probably not causing their problem, okay? We will print you out and show you lots of pretty rhythms, okay? And then the first time you get your patient that, you know, has underlying cardiac disease and has a couple of underbranch blocks, and you do a 12 lead and you're like, crap, that looks really bad. But they broke their arm, and that's their normal. The problem that we have is that we don't have anything to compare to what their normal is. Whereas the hospital can pull them up if they've ever been there and look at their normal, you know, what their last EKG was. So sometimes it'll look really horrible, and you'll be like, oh my God, I never saw one like that in cardiology. Okay. But that's why you have to go through and look at it the same way each time and go through the rules in your head and what's the rate? Is the rhythm, is it regular or irregular? Do they have P waves? Are all the rules normal? The PR interval, the QRS, the PR, okay, I said that, PR intervals. So that's why we have to do it systematic, because you will get messed up if you don't do it right. Okay. We threw a lot at you. I'm going to upload this into Brightspace. I remember the name of it. So that you can look at it. Okay.
This is something that's really good to make some flashcards on,
Yes.
like your rules for EKGs, what fits in your regular parameters, what to, your list of things you look for, regular, irregular, narrow, wide, are there P waves, all that kind of stuff. And then rules for each, specific kind of rhythm. It's a really good idea to make some flashcards for that.
And when you make flashcards, you kind of remember it, because you wrote it. Alright, so I have more pretty pictures. Oh, wait, they're different. Oh, you did them in sets? How lovely.
It's on the first day.
Alright. So there's some more handouts for you. There's pretty pictures.
Bad. Squiggles.
This top one is kind of cool in that it gives you a mnemonic
This is also
to remember the heart valves in the order. Try pulling my aorta or toilet paper my arse. Whatever works, right?
What for fall?
So we're gonna practice the rhythms after you're done pushing and blowing.
Thank you. I'm really good. Take it away.
Did I get everybody?